Hello and welcome to the Answers for Cancers podcast. I am your host, Anne-Marie Fay.
And I'm Michelle Matthews.
Together with some of Ireland's leading experts, we want to unravel what it truly means to have cancer.
From consultant diagnosis to treatment plans, from managing your symptoms to supports available, we have it covered. So whether you're a nurse working in oncology or have been personally affected by cancer, this podcast is for you.
Today on the podcast, we're joined by Linsey, Blair, individual and couple psychotherapist and psychosexual therapist. We know that in some cases, after a cancer diagnosis, there can be a mourning period, and communicating throughout that time with your significant other can be very challenging. Today, we discuss strategies to help couples communicate around the area of intimacy after a cancer diagnosis. Linsey discusses communication around sex, readiness to have sex after a cancer treatment, accepting things are allowed to go wrong, approaching this topic with your healthcare professional, and managing some side effects that come with certain cancer treatments, such as pain and vaginal atrophy. She also helps us to understand the use of dilators and how they work. Linsey has come highly recommended after a talk she did on this topic with our ARC Cancer Support. So thank you, Linsey, for covering this topic.
Good morning, Linsey. Welcome to the Answers for Cancers podcast. Thanks so much for meeting with us today. We might just start just with a little bit about yourself, just about the work that you do, and if you've worked with many people with a cancer diagnosis.
So I'm a sex therapist, and originally I trained in couple therapy. So I work mostly with couples who are struggling with sexual difficulties. And since I come to Ireland, I've worked a lot with cancer, mainly because I got engaged with the 221 Plus group. So that was my way in. And then through that group, I started doing quite a bit of work for Cancer Care West, and then I've done a bit for ARC. And so we have a lot of clients come in because obviously cancer treatment is one of the main illnesses that can directly affect the ability to have sex, sexual pain, and vaginal atrophy, and all the things we might talk about today come out. So I would certainly see quite a few couples who have been through the cancer treatment.
Mm-hmm. We've done actually a good bit of work with ARC, and you're the one name that just keeps coming up and again and again and again, because anyone we've spoke to just absolutely rave about you. So you're doing amazing work. So thanks for everything that you're doing for these people.
And I suppose I might jump in with one of the first questions. So there can be a mourning period after a diagnosis or after treatment, and people are left with significant side effects after treatment. Can we chat a little bit how couples might communicate around this time?
I think that it's very different for sex and other topics. And I think that's true for everybody, not just for people who've been through cancer. I see couples who are really good at emotional communication and are completely silent in the bedroom. I feel like you can have couples who are talking a little bit about maybe the trauma of the diagnosis. What we also have to think about is the impact on the partner as well, and the family, because I think that often goes under the radar.
Yeah.
Certainly I had a couple yesterday where he was the man who'd been through testicular cancer, but he was saying, actually, I think my wife has a trauma because she watched him go through it. And that was really hard to talk about. And as soon as he said that, she burst out crying. So it felt like she was holding a lot, and they had young kids and trying to keep it all together. So the mourning isn't only for the individual, it's for everybody. There's changes within the family dynamic, within the couple relationship. Around sex, I think it's particularly difficult because I think couples have an idea that they want to get back to the way it was. That would be the most common thing I hear, right? So usually when people start sex therapy, I say, what would you like from me? And they say, we want sex to be the way it was. And I always say, look, I can't give you that. We could do something completely different and even be better. And that's what I'm really trying to push. But in order for it to be different and better, you have to let go a bit of the idealization of the way it was. And sometimes when we explore the way it was, it actually wasn't that good. Because I think when things work, well, they work. You know what I mean? It doesn't have to be a conversation. Or don't have to say what they like and what they don't like. What works. They like touching here, they like touching there. There's no negotiation. Sex tends to follow quite a rigid script that maybe happened when the couple first got together and still keeps happening if it's working. When it's not working, people start talking. And that's when I think sex can get really exciting.
So would you say that it's really important to acknowledge, I suppose, the trauma and the mourning of just what's happening in general before you even approach the subject of sex or intimacy?
Yeah, or both combined. like, I think that idea of trying to get back to the way things was exists everywhere. Do you know what I mean? About, you know, people try to get back to the way they were working, the way they were doing, and ignoring their tiredness, everything. There's a real desire to go back. And the whole family system tends to support that. So even around sex, like one thing I often hear people say to their partners is like, oh, you know, I really don't notice the mastectomy. I really don't notice it. You're exactly the same to me. And I think that's a really nice thing to say, and they're saying it for a reason, but it isn't true. It's a little bit of unconscious gaslighting, because they're like, well, it's not the same. So that idea as well is sort of an avoidance of going, this is so sad. I've lost something, but it's okay, because we can maybe gain something if we move from that loss. Do you know what I mean? We can gain knowledge of how to, what else in your body, if this breast has lost a lot of sensitivity, what else is sensitive? Whereas if they keep going on with sex they used to have, you know, touching the breast that has no feeling, everyone pretending that it does, or it doesn't matter that it doesn't, people don't want to go back into sex because it just doesn't have intimacy.
Yeah, it's really interesting what you're saying there. You differentiate that they're two very separate things, sex and intimacy. Would you be able to just, I suppose, just explain those two constructs and what the difference is?
Well, again, I think it's a sort of myth of sex therapists. You know, people think that we're like, you know, trying to get very penetration focused as well. People think we are, let's get the goal, let's get sex. It's not, we don't care about sex. Honestly, I think sex therapists don't care about penetration and orgasm. We don't even care that much about the genitals. We care about intimacy. And I always say, like, and it was said in your email back to you as well, is that intimacy is when things go wrong. It is not when things go right. Because when things go wrong, it's when you're exposed. And when you sit with your partner while feeling vulnerable and maybe shameful and maybe upset, and you say, I'm really scared to do this because it's going to hurt. That's intimacy. That's that moment. And their response is like, oh my God, I'm scared too. You know, let's try to do something different, and then maybe they just do a massage that night and have a kiss, a hug. That would be more intimate than, you know, the guy taking Viagra, trying to get the erection in, everyone very silent, it doesn't go in, nobody talks about it. Intimacy is really just talking about your feelings, and you can have that without necessarily having penetration. And what I do with couples is I really try to build in that intimate emotional connection before we even go to the sites that are causing issue. Do you know what I mean? There'll be a lot of chatting and negotiation, everyone's feeling comfortable, everyone's playing, and then we might go, okay, so now let's go to the genitals, start exploring down in the genitals and seeing what's happening down there.
For people who are listening who are thinking, we haven't had sex since I've had a cancer diagnosis or my treatment is complete, how would you suggest, or would you have any tips for how can they start that initial conversation if they think, okay, I think I'm kind of ready to start, I think I want to try, but it's been a long period of time, I don't feel like myself. Do you have any tips for how people might initiate, whether it's the person with the cancer diagnosis or the partner, how they might start that conversation off, the initial conversation to say, are we going to try again?
Because for some people, it's been a very long time in some circumstances, years in some circumstances, you know, so it can be so taboo for people to even broach the subject.
I know. There's no real side doors in there. Like, you know, I mean, when I train, say, healthcare professionals who are also very nervous, can be very nervous about asking about sex, I always say, say intimacy first. Say, you know, we haven't, if it's a healthcare professional, they might say, oh, you know, when was the last time you were intimate with each other? With partners, I would say the way to go in is go, you know what, it's been a long time since we had a hug. Because I guess what you notice with sex is that when sex becomes avoided, and this is the saddest part of it, I think, because it's around the intimate connection, it's when people get scared of sex, they get scared of touch around sex because sex itself becomes so loaded. So then they think, oh God, if I go and like hold his hand, he'll think I want sex.
Yeah.
And he might do, because at that time there has been no sex. So as soon as she does that, he's like, okay, brilliant. So we'll feed into that loop. So then people start withdrawing physically around everything.
Yeah.
So I would say, like, if you go in and, you know, say something, we haven't had sex for a while, love, what's happening? That will immediately, everyone's going to be straight and tense, and there'll be awkward silence, and everyone's thinking of penetration. So I think the way in is just to be like, I really miss like the way we used to sit together, man's walking down the street, or, you know, there's so many other different types of touch. That's what we would build in, you know, when we use a program called Sensate Focus. And sensate focus can start where you want it to start. I have couples now who are literally sitting cross-legged exploring each other's hands. Mm-hmm. That's all they're doing right now, and that's good. Mm-hmm. And then eventually it will move up, and it doesn't include breast, bum and genitals. It's just a soft touch all over the body, including lots of different erogenous zones like the lips and ears, and a couple of chatting, negotiating, saying what feels good, saying what doesn't feel good. We might bring in oils, and then we slowly, like I tell my couples, it's like the dial of a cooker. We just turn it up by one dial each time in the exercises. So it almost starts getting sexy without people noticing it's getting sexy. Do you know what I mean? But it's a very slow, intimate reconnection. Not putting couples in the bedroom and saying, you know, here's the vacuum pump, here's this, go for it. You know, it's very slow. And I think that's where couples have to start.
Yeah. We've heard you speak a lot before, actually, about the difference between female desire and male desire. Do you think that it's really important for couples to acknowledge this when they're going into conversations regarding intimacy and sex?
Yeah, absolutely. There is definitely differences between female and male desire, which is mostly linked to hormones. And I'll talk a bit about those. I was running some cancer groups and we were all having a real laugh around the female model of desire, because it's really, I think it strikes a lot of women and men who've been through the hormone treatments as well around cancer, and they really relate to it. And so, first of all, I think the way people think desire is that it follows a very linear model. So you start off wanting sex or feeling horny, and then you might touch your partner, and then your body will kick in. And so early arousal might start, and your pupils might dilate, and your vagina might dilate, and you might lubricate, or you might get semi-erection. And then it kind of goes up from there onto plateau orgasm, and then resolution is the time it takes for the linear cycle to kick off again. But actually what we now know is that women are in a very different cycle, and we call it the cycle of neutrality. And I often describe it like this, but it's when you could have sex, but you could also watch Netflix. Or you could have sex, but there's loads of dishes to be done. Right? So it's like sex is in there somewhere, but it's in a massive list of other things that you could do. And to be honest, the other things are often a little bit easier and more relaxing. Right? So sex kind of would drop off there. When we ask women like about what took them out of neutrality, and I think this is really, really interesting bit, like what helps you like want to have sex? They never, very rarely said physical touch. They said, when my partner does the dishes. Wow. They said, when I see him reading to the kids at bedtime. Yeah. So it was like things that were non-sexual that made them look at their partner and go, oh, he's kind of nice, but not physical touch. When you're in that state of neutrality, like when you kind of could have sex, but you could also be doing this and your head's a million places. If someone comes and initiates by grabbing your bum, you're going to go like, get the hell off me. Do you know what I mean? Like, it's like too much. You're not in that state. So it's about trying to find the lead in. And then the other interesting thing was about then when women are there and they might be kissing, touching, and they actually start showing signs of early arousal. So the heart rate's going up, the pupils are dilating, the vagina might even start to kick in and change at this point. They're still thinking about Netflix, right? So women's minds are still not there even when their bodies are coming in. So desire is not the place they start, it's usually the place they end. So there's a point in sex where you go, oh hey, I really like this, but it's often on the climb up to orgasm. Yeah, you know, you're like, boom, I'm now in. Yeah. And for a lot of women, because sex can be very penetrative, focused, and quite fast, they never reach that. The other interesting thing is that when women were interviewed about what made them want to have sex again, what makes them then keep sex in their minds and be more likely to move out of neutrality, they very rarely said orgasm. They usually said postcoital intimacy. And we just say that's a hug after sex. So what women rated as a best sexual experience was one that ended well. And they said ended well, and it's just lying in a hug. I always say to my couples is you can have that bit no matter what else happens. If the erection's lost, if there's pain and you can't do it, if there's a bit of leakage, like, you know, fetal urine leakage, you can still have that hug, and it will still end in a good experience.
I suppose it's allowing things to go wrong, isn't it?
Yeah, being okay with the fact your body's different, and we're all different, and we're all human, and nothing really works the way it should anyway. Do you know what I mean? Whether we've had cancer or not. I think when a lot of people come in saying they have low libido, they're actually usually have honestly, generally quite normal libido for what they're going through and for what their bodies are going through. It's just they are again pushing themselves to be somewhere different. That makes sense. Rather than accepting where they are. Where they are might just mean you need a different way in. You'll still get that stomach feeling and that tingle, but it's just going to be a different pathway in.
Reminds me of what we spoke to Mary Rogan last year, and she said so many times that we should settle for good enough, and then you go from there. And it was just I think it's a really good way of putting it, isn't it? And I think as well, like, you know, you hear a lot about people saying, oh, my sex life, but actually, like you say there, for women, it's not separate to life, it's just part of everything. So there's no separation, it's part of everything.
I suppose from a point of view of a cancer diagnosis, a lot of patients will have a leading consultant or oncology team, and sometimes these conversations can get missed in those rooms. Do you have any kind of tips, I suppose, on how people can approach having these conversations with their treating team to make sure that they're fully educated on what they can do, or even as healthcare professionals, how we can bring up these conversations to make sure that they're being spoken about?
I mean, again, you know, when you're asking about the couples, there isn't really, just has to be said. There's no kind of way in or around. Like what I did say to healthcare professionals is if you're feeling nervous in yourselves, always start with intimacy. Do you know?
Yeah.
I do that as a sex therapist. I do that with my couples. Do you know, they walk in the room, even if they're bringing sex, you know, that might not be the first thing they say to me. So I would say, and how are things like, how's intimacy between you at the moment? And I go, hugs, hand kissing, sex, penetration, are all these things okay? So you kind of give a little list lineup, but it's a really difficult one because certainly in London, I did train healthcare professionals in talking about sex, and you have very different feedback around what is happening there. So a lot of them will say, we really do talk about it, but it isn't heard. Whereas a lot of the patients say it was never mentioned. So I don't know what the truth is, but I think probably what is happening is it's talked about in a list of other things. I think people are going, here's the consequences of what could happen, diddle-a-diddle-a-da, erectile dysfunction, diddle-a. But among that, there's loads of other bits. And at that time, you're already flooded with cortisol. Do you know what I mean? Your frontal lobe is probably not, you know, your narrative memory of those events is often very shut down. Like when you talk to patients around what happened when, they often don't remember a lot of what was going on through the treatment because they're just in survival mode. And, you know, people are talking about sex life. You're a bit like, oh, I just want to live at the minute. Like, I don't, do you know what I mean?
Yeah.
Why are you talking to me about my vagina or my penis?
I think you're so right. Like from my experience on the ground as a nurse, you know, usually it is in conjunction with loads of other information, you know, so it's not kind of set aside the time that it deserves. And I suppose that's because of so many other reasons, I suppose, just resources and time and all those other things. But yeah, it's definitely in the mix, and it's really difficult for people to be able to absorb everything that's thrown at them at that time.
Totally. And I think people at the time don't really, you know, like I was saying, like the problem is when you start avoiding sex, you start avoiding lots of things. And I don't think people really understand how important it is when sexual dysfunctions hit. They could be dismissing themselves, like, oh God, well, I don't really care. Do you know what I mean? We're having sex once every 3 months anyway, like whatever.
Yeah.
Do you know what I mean? Because it's not like everyone walks in pre-cancer diagnosis having an amazing sex life, you know, and none of us are doing that, right? So like it's not like oh my God, I'm having sex every day and from the chances. So I think people also are a bit like, well, it doesn't really matter, like sex is in there, but it's not what holds a relationship together, and it's not what defines me. They're more focused on other things.
Definitely, yeah. One thing I suppose that we see a lot, I suppose it's while patients are on like hormonal treatment, which we touched off there just before, is vaginal dryness that can cause a huge amount of issues for people trying to, I suppose, have any intimacy or sex. Do you have any recommendations for how people can manage this or try to help in any way?
Yeah, absolutely. So what we would recommend is vaginal moisturizer. So, and I recommend this for everybody, not just people being through cancer. So I'd always say if you moisturize your skin after the shower, you can moisturize your vagina. It's got the same skin on the inside. So you have dry skin, you're likely to have a dry vagina. So you can buy vaginal moisturizer now. The product we're recommending, am I allowed to say product? The product we're recommending is Yes.
Yeah, so I suppose it's fine to recommend any products, but just a disclaimer, I suppose, if anyone's listening that is hormone positive driven cancer, such as ER positive breast cancer, any products need to be free of estrogen. So just check that with your pharmacist or your doctor before you start taking anything. But yeah, I absolutely recommend anything else.
So the products we recommend, it's one called Yes, and at the moment it seems to be, I mean, there's other ones that are very close like Silk, but it seems to be the one that is closest to the vaginal pH, which is what you're trying to get. The problem with a lot of lubricants, and a lot of people might use kind of over-the-counter lubricants like brands like Durex, a lot of the issue is when you put them in, your vagina gets very wet. Yeah. And then your vagina compensates after sex by becoming much, much drier. Yeah. So your vagina is always trying to find the right pH. So if you're not getting a lubricant that's absorbing really well, then your vagina will start getting drier, and then you might end up in like cycles of thrush and things if you're getting too wet and too dry and too wet and too dry. So Yes seems the closest right now.
It's mad to think that that's just it's not mainstream information. People think, oh, I'll buy lubricant because that will help with dryness, but actually you could be doing more damage than good.
You could be doing more damage, yeah, because you will actually cause more dryness in the end. So we would say use Yes lubricant, the oil one, if there's a lot of dryness. So that's the one I would recommend for women who had like hysterectomies, who were pushed into the menopause, or for menopausal women in general, because it's a lot thicker. So what happens is your walls also thin. If you've had a hysterectomy, so you can have a little bit of bleeding as well. So the oil will create another surface. So I would say oil-based lubricant, mix the oil in with the water, gives it a better absorption, and use vagina moisturizer regularly.
And I suppose keeping on that topic, some ladies can experience vaginal atrophy after things like pelvic radiation and things like that. Do you have any kind of recommendations or tips on how patients can manage this?
It's really dilator work. There's a difference between the atrophy and the shortening of the vagina. Shortening of the vagina, which can often be due to scar tissue or surgery. Dilators usually won't help with that. That's usually like a kind of a blockade. You might be able to get it open a little, but not a lot. So the product used for that, and again, this is one people don't know about a lot. It's called the O-Nut for vaginal shortening. You can get it on pelvichealth.co.uk. But it's like, it looks like, one of those kids games where you put the rings on top of each other, and you put the rings on the end of the penis. So you basically shorten the penis, and they're squidgy rings, you see. Shorten the penis to the same length as a vagina.
So you keep that on during penetration?
Keep it on, but it's squishy, so you can go in the vagina and they squish.
Oh, okay.
You get 1, 2, or 3 rings, depending on the time. So that's for the shortening. The atrophy is really dilator work. Which is crap. So I'm always trying to find a way to make it a little bit better for women.
We hear a lot of time that people are afraid, to dilators and things like that. Is there any websites or videos that patients can watch to, I suppose, just to get some demonstrations and stuff before they go off and just try and use them themselves?
Well, they usually get the Emil Comfort ones, the ones that are handed out. I think it's here as well, which are the plastic ones. Now they do come with a video.
Okay. Yeah.
So they should anyway. In their pack, there's a little DVD of how to use them. But the way we would recommend using them in sex therapy is different. We would recommend, first of all, and it depends on what's going on. So the plastic ones are quite good, say if there's a lot of burning and pain, because what you can do with the plastic ones is you can put them in the freezer. They actually absorb the cold quite well, so that will help as a numbing effect when you're going in, and it can actually be quite soothing if there is a lot of burning.
Okay.
So putting them in the freezer is quite a good tip. But normally what I would recommend is the silicone ones with a bend. Okay, they're just a bit, and they look really pretty now. So like you can get them on Love Honey, Joe Divine, Shush. And they come in a little like multicolored pastel set, a little handbag, and they have a lovely bend to them. Yeah, which is true for the penis as well. It's not a solid thing. It will bend against the vaginal walls. And then I get women to use the dilators in a way that we would call self-focus, right? So that's like, I might get them starting the bath or on the bed, and they touch their whole body first. So they try to get themselves grounded within their body. Maybe moisturizing themselves, doing something if you're in the bath, you're just stroking your whole body. And then I get them to cup the vagina, right? and rest into the cup. And this involves your shoulders going down. And what's so important is your jaws relax. So your spinal, the back of the door is connected to your pelvic floor, right? So if your jaw is tense, your pelvic floor is tense.
Yes.
Okay, so that's increasing the vaginal atrophy, right? And that very hard to sort those two out. So with atrophy, there's pain. And with pain, you go like this. You brace yourself for the coming of the dilator or the penis or whatever. And so you're tightening the vagina, and the vagina is naturally atrophied. So that's when you get really stuck. So make sure your shoulders down, your jaws relaxed. And then I would say just put the tip in of the smallest one, just the tip. Check again, you're relaxed. And then you turn it in a little bit more, turn it. The turn is just to relax any muscle tension there as well. You're using a decent lubricant like the Yes, the oil. And then when you get it in, you just try to rest and relax with it in and sit with it in for a few minutes.
What you're explaining sounds like more of a mindful practice as much as it is a physical.
Much more mindful, yeah. I mean, I always joked about this when I had it blended. I was like, she's like, the dilators are not working. And I was like, well, tell me how you're using them. Tell me through the dilators. She's like, well, I'm sitting up and I'm sticking it in. And I was like, well, what are you doing? Like, are you in your bedroom? She's like, no, I'm watching Breaking Bad.
Oh gosh.
Like, watching Breaking Bad? It's like, but that's like really like there's loads of violence and like it's horrible. Yeah. And I do think, when we talk about mourning, I think there's a lot of anger with genitals that don't work.
Yeah.
I think people get really angry with them. And sometimes I think they can use the dilators out of anger. So if you're trying to shove something into it, it's just going to react and get more tight and more scared. So you really have to have conversations with yourself. Like, it's okay. I get people to talk to their vaginas, say, it's okay. Here's what we're going to do. I'm going to put it in. I'm going to rest. It's going to stay there for a few minutes, and then we're going to do something really nice. And I get them to do something nice after the dilator use, which might be paint your nails. You know what I mean? Do something here. So it's not so much like this awful task. It's involved with something else that is pampering, and to try to build it in with that.
And can I ask, this might seem just like a really basic question, but I suppose just for anyone listening who doesn't know, what is a dilator and what's the purpose of a dilator?
Okay, so the dilators look a little bit like the vibrators now, and they start in a small size. So the first one is usually the size of your little finger. Second one would be roughly tampon. The third or fourth one is average size of the penis, and then there's usually one bigger, which is really psychological, the last one often. Yeah. And the idea is they just open up the vaginal walls. They're just stretching the vagina. So we would use them as well as with a vaginal atrophy that has been caused by cancer. We would use them for psychological stress, as well, because there's vaginal not atrophy, but the pelvic floor will tighten.
Yeah.
So you just put them in and they stretch out. The thing about the dilators, though, with the cancer treatment, which is different from the kind of psychological treatment, is you can't ever stop using them. And I think women are often really surprised by that. So they'll use them for a bit maybe and have penetrative sex and they're like, great. And then it will all fade away again and the vagina will start. It's a constant battle. The vagina is always going to try to close. So if you really want to keep penetrative sex as part of your menu, you have to keep using the dilators. So again, it's just about building it into your routine with something nice.
And how regularly, I suppose, should people be using them after a cancer treatment, or is there a specific, every alternative day, once a week? Is there a specific time how regularly people should be using a dilator?
It depends, right, on the treatment and on how bad it is. But really, at first, I would say 3 times a week. Okay. You might be able to go down to once a week.
Yeah. And when it's in, then, sorry, I'm just thinking of the questions, I suppose, that I'm thinking of that I don't know the answers to. When somebody has a dilator in, is there a particular length of time they should leave it in for? A couple of seconds, a couple of minutes, or does it just...
Minutes, I would say minutes. So try to rest with it in. Like, sometimes I get people to do it to relaxing music. And I say, try to leave it in for like half a song or so. So we'd be talking like 3-4 minutes.
Yeah.
Don't do any harm left in there.
Yeah.
The longer you can, the better, but not to a point it's getting really uncomfy.
And should they, are they usually provided by their treating teams, to say, for example?
They are. So they usually get the plastic ones, you see, and then a lot of women are put off by the plastic ones. Like I've said, they are better in the freezer. They do hold cold better than the silicone ones, but they look very clinical. Yeah. They're white plastic. with a screw, screw in and then do it. So they don't look good. And I think women associate them as well with the hospital because they were given in the hospital. So you have to remember that then when people walk into the hospital, there's smell, and that whole smell will bring them back to treatment. So the bag in itself gets demonized. That bag, like I ask so many women, I'm like, where are your dilators? And they're just like in the fucking bin.
Yeah.
Or they're hiding the bag and they don't want to see the bag, and the bag brings them back. So like, I actually think, if you can afford it, choose your own.
Yeah.
It gives you a kind of a sense of power as well over what you're doing. Like, this is what I'm doing, not what someone told me to do. Like, I'm doing this for me.
Yeah.
And we do sell really nice ones now.
And I think you did give us a website, sorry, to get them on. I think you did.
The dilators you can get most places. So the way I get people to get dilators is I get them to go in a sex shop. So the ones would be Joe Divine, Love Honey and Shush. They all deliver to the UK. And what I get couples do, when I say like combine it with pleasure, is I'll say go in there, get the dilators and get a toy for yourself. Same time, right? Get like some for your clitoris, get something like a little mini vibrating bullet, just get something nice at the same time, and you can use these things together. I would never try to get women using dilator 3 or 4 when they're not aroused. And that's true whether we are whether we have cancer or not, because none of us want to put something this big up us when our dilator, when our vagina is not dilated and we're not in an arousal state. So they have to also be included with a bit of masturbation, which a lot of women do not realize. They're trying to do them all in an unaroused state.
Yeah. And I suppose that kind of brings us on to one of the next questions. Sometimes the clitoris can be affected after surgery, and we know that's important for women to achieve an orgasm. Sometimes there can be a loss of sensation, or it just might feel a bit different or numb. Do you have any kind of tips on how people may be able to sort of experiment with themselves with finding pleasure, or else communicating with their partner around this?
I mean, again, a lot of that would be back to the sensate focus, right? And finding different erogenous zones in their body. They will be there. I often say to people, the bit that you really don't like being touched, that tickles you during sex, that's probably your erogenous zone. For a lot of people, it's a feet. They're like, like that's actually the place that you should start integrating, because that's usually one of your erogenous zones. But also, the clitoris is a really big organ. So the tip of it is just the bit you see, otherwise a big Y that cuts through the kind of first third of the vaginal passage. So even if your outer one is affected, your inner one may not be. That's on the back passage in the first third of the vagina. So you can play with the inner one if that's comfy enough to find. And then I'd just be working on finding different sensations all over the body, and really remembering that it wasn't the orgasm that women reported in sexual satisfaction. And a lot of the time women are not achieving orgasm anyway, right? Because the dissolve cycle is a lot slower. So it's not a guaranteed for women in sex. In heterosexual sex, people sometimes come up with very solid reasons not to engage in anything. Well, there's no point because I can't have an orgasm. And I say, well, did you have one every time before?
Yeah.
I always say to people, it's not the dysfunction in itself that is the problem here. It's not being able to talk or think around the dysfunction. It becomes much bigger than it has to be.
And I suppose we spoke prior to the recording around, I suppose some people may be left with a catheter after they've had specific surgery or anal issues. And I just think it's important to acknowledge this group of people. And you mentioned it's not always about penetrative sex, but just working alongside your clients to find the best answer for them, depending on what that might be, and just getting them comfortable.
It really depends on what people want to do and what they're able to do. I mean, some people will tape up the catheter. Some people might wear underwear that might cover a bit of it. So it just depends. A lot of it, again, is just about talking and thinking. I think the way we judge ourselves is often much more harshly than our partner will judge us. I mean, I remember working with a couple where there was anal leakage, and that was just, she just did not want to go to sex because she was just like, he's going to be completely disgusted. When we did the Sensate program and we got there and stuff, one of the things I was saying is, that when you do leak anally, it's when you're aroused, right? So it's usually on the build up to orgasm when those muscles start to relax, that there might be a bit of urinary or anal leakage. So I was saying it actually means you're on the right path. And he was so pleased by this. He was like, oh my God, really? So I'm like, that's like, she's really aroused. I was like, yeah. And he's like, that's so cool.
Right. I think that just shows the power of actually just talking.
He really didn't matter. He was actually really pleased that now he had a better sign. He's like, she never tells me if I'm doing something right. I was like, well, now you know. I think a lot of it is about de-shaming.
Which I think is something that I suppose in Ireland, just historically has just been there for such a long time.
Yeah.
This kind of topic. So it's great to see all these kind of conversations becoming much more mainstream. So I think bit by bit, we're kind of hopefully getting there with de-shame and everything.
Absolutely.
I suppose another thing that we've seen you mention on previous kind of interviews and stuff that you've had that we thought was really important to mention is just that you said before that everybody will experience a sexual dysfunction at some point in their life, whether that's to do with cancer diagnosis or not. And we just thought it's really important to actually just acknowledge that, because people need to hear that, we think.
Yeah, I mean, of course. It's not like I work with cancer, but I work with everybody. Like a lot of women who have kids with sexual dysfunction, pelvic floor dysfunctions after childbirth, really common. But for all of us, it's just naturally aging. And I think what happens with cancer, like certainly, in the radical hysterectomies and things, women are a fast forward of the aging process in the body. Do you know what I mean? You get real fast forward, so the vagina starts altering. But we will all experience a lot of that stuff as we get older. And a lot of that, like we were talking about before, is about mourning. It's really about mourning. I think men struggle with that a lot in terms of like wanting the erection to be a certain way, to last a certain length of time, and really identifying that with sort of male potency or power can get really intertangled. Whereas actually, like for everybody, the bodies are kind of aging at roughly the same point. So it's really about being able to write a new sexual script depending on where your body is at that time, and just being able to negotiate it, So like, actually, my erection's not hard enough. Well, that's fine. Let's do this. And it can be really great doing the other thing and much more intimate, like we're saying. So I think, everybody needs to start talking and chatting and thinking about the sex that they're having, sex that they want to be having, and what will happen if they can't have the sex that they're having, and where will they go from there? What's next?
I'm conscious that we've kind of predominantly covered women for the most part in this podcast, but we do have one with Dr. Mary Rogan, which kind of more focuses on the male side of things. But something that I have really taken away, and I suppose maybe it would be good for couples to hear, who've had a radical prostatectomy or anything, that it's not always about penetrative sex, which is what we just constantly associate with sex. And I think even initially the first, batch of questions that we had sent you were so focused on that, and it's only when you actually look at the bigger picture and everything around it, there's just so much more to it.
Yeah, so much more to it. Yeah, there's a nice one I always tell men, the circle of failure. It's about erectile disorder. So a lot of erectile disorder can be physiological. Actually, most of it's psychological. And it's about, just fear. And I always talk to men about the cycle, where it goes a bit like, the idea is you have a random erectile loss, and that could be for a really normal reason, right? So post-cancer treatment, you're nervous anyway. There may be erectile problems because you've been told that. You may even be taking Viagra, maybe the first time you've taken it, and that increases your heart rate, right? So if there's any anxiety and you're not used to taking these tablets, you tend to feel more anxious rather than more sexually aroused. So actually, Viagra and Cialis can cause anxiety. Do you know what I mean? They don't necessarily work. And so people are in sex, it's a heart, feeling nervous, and they're worried it's not going to work. And all they're doing in sex is they're looking at their penis. So whatever's happening in sex, they're just glancing down the penis. You're like thinking, oh God, it's not hard. Why is it not hard? Can't believe it's not hard. It's always hard when she's doing this. This is it. Now we're going to have that dreadful conversation. And when I say that in the male groups, they're all laughing, because they're like, that is so true. And I'm like, well, what? Like, what is arising in that? What is arising about you staring at your penis and just worrying about it? I was like, nothing sexy is happening. Like, of course it's not going to come. So like, there's a real penis watching that happens to men with ED. And often it's both partners looking at the penis and worrying about the penis. So there's nothing sensual or sexy happening in that interaction. So often all I get them to do is put boxers on, so they can't penis watch, and just stay in the moment and leave out genital touch, and then just see if it's going to come naturally when they stop thinking about it so much and relax a bit. And then if they need to take Viagra and Cialis, I would tell them usually to take half a tablet first, by themselves in masturbation. So they get used to the feeling that it brings on in the body, because otherwise it can't be interpreted as more anxiety.
Yes.
And then it feeds into that loop.
Yeah. I think that's the biggest thing I've taken away from what we spoke about, is that it's hugely psychological and emotional. And sometimes if we can steer some of the energy towards that and away from the physical, sometimes maybe we might be able to come to a solution for everybody.
The physical solve is not the solve. It's just a way to avoid talking about the issues a lot of the time.
This has been brilliant. Thank you so much for your time and everything you've given us. I'm just wondering, do you think there's anything that you think is important to mention for any of our listeners that we might have missed out on?
I mean, I think the most important tips is to, like we were saying before, build up from scratch.
Yeah.
Park the place that's causing you distress, right?
Yeah.
Off the genitals. Don't go there.
Yeah.
I would say the thing about sex is that when it starts to become unplayful, when you start to become nervous about going into it, and it starts getting really serious, when you're worried about crying or not speaking afterwards, things need to really, really change. And all you want to do in sex is play. All it is. And play has no right or wrong. Like I always say to my couples, it's like building a Lego castle, right? Don't have an image in your head, because it's never going to look like that image and you'll only end up disappointed. Just both of you add blocks and see what comes out. So it's really just about playing together. I always say, don't call it sex, call it play. We'll just play.
Yeah, I'm just thinking for the couples maybe that find it really difficult to start the conversation. Maybe they haven't actually acknowledged anything, but it's a real issue. What do you think the first step for them would be? Do you think it would be to get into a room with somebody like yourself, or an individual counsellor, or what would you suggest for that kind of situation?
I mean, if they're really struggling and can't talk about and going to the words, I would say, yeah, absolutely, come to a sex therapist with your partner. Sometimes people are really nervous and they come by themselves first off. And then they kind of might meet us and know that we're not really scary, and then bring the partner. That's fine if that's the way to do it. But I think sex therapists are really helpful because we just name it.
Yeah, absolutely.
We just name it. We're just like, what's happening, what's hurting, how's it going, what's feeling, who's scared, who's in the middle. Do you know, so it's the conversation happens in session one, and it's, you can see everybody relaxing when we're having it. It's not at all like people expect. It's the opposite. Like everything goes down in the room and everyone starts talking. It's that bit, isn't it? It's the getting into it. Like it's that first thing that people find so hard. But when you're in, you're in. And it's the same with sex therapy. People are so nervous in a waiting room and they come in, they're like, ugh. 15 minutes in, we're all there and we're all chatting.
Yeah.
Thank you, Lindsay. This has been so beneficial, and I'm delighted we could get you on the podcast. As Anne-Marie said at the start, we've had loads of people mention you, so this is brilliant. I'm delighted that we can get it out to more people.
And I suppose if anybody is interested in reaching out to you, do you offer that service? Are you in person or Zoom, or what way do you operate?
Well, I'm based in Galway now. We're an evidence-based therapy centre in Galway, but right now I run a team of 5 of us. And the other 4 are all online, based in around Dublin or the UK, or we're all similar Tavistock training and stuff. So we're all sexual criminal therapists. So yeah, we'll be happy to work with people.
Brilliant. Thank you so much. Fantastic. And happy Friday. Hope you have a lovely weekend.
Yeah, same to you guys. Okay, bye.
Thanks for listening to the